Dr. Sunil Sharma now. Just one sentence is enough. If you want to know what he is, go to Google and put Gauss Labs. You will get to know. But that is not possible right now, so I'm going to say a few words about him. He is one of the most fascinating persons I have seen. He is a member of the Royal Society of Chemistry. And most of us script saying that there is no new antibiotic after 2006. What have we done about it? There's a certain number of people trying to do alternate methods of getting a new drug, and he is one of them. He is a PhD in synthetic organic chemistry from UK, a winner of many funding awards. He is a member of the Royal Society of Chemistry and an active researcher with more than 40 publications, journal, textbooks everywhere. And he is a synthetic medicinal chemist with an interest in synthesis of bioactive molecules and analytical tools for biochemical processes. And his research interests include total synthesis of natural products. If you don't understand what I mean, he's making antibiotics out of natural products. And that's going to bypass the standard procedures. He's an expert in genochemetics. It's a new paradigm. Gene expression enabling selective diversification, catalytic carbon-carbon bond forming reactions, and its application like production of imaginees from where to where, antibiotics, anti-cancer drugs. Wonderful. He's doing excellent work with tremendous repercussions in the field of medicine. With this formal introduction, though it is not really adequate, I, with great pleasure, present to you our star speaker for the day, Dr. Sunil Sharma. The stage is yours, sir. Thank you.
Thank you very much, Dr. Bhat. It is really kind and overwhelming introduction. Thanks a lot. I'm just wondering, do you see my screen, the presentation screen?
We're able to see your screen, sir.
Okay, good, because I see nothing else except my presentation screen. So I'm talking to myself now on computer. That's what it is. Yeah, so I must thank all the organizers. Professor Bongare, he's a very old and dear friend of mine. We are associated for over 20 years now, and I could never refuse his invitation to be involved with this conference. I feel privileged to be in fact part of it. And when I see the list of speakers and the program schedule, I find myself a little odd person in this group, because I come with a heavy medicinal chemistry, analytical chemistry background, and the next speaker is going to talk about the clinical. So, but as most of us have a background in pharmacy or pursuing pharmacy, so a pharmacist is supposed to be an all-rounder. That's what I believe, and that's what we all are. So with that pretext, I hope I'll try and make this talk amenable to majority of us. I'll also try and avoid a heavy, hard chemistry discussion, although what you are going to see would be overwhelming. There's lots of chemistry, chemical structures, but that's how it is. A pharmacist is supposed to be expert in everything, and we serve a big purpose in society as well. So being a pharmacy practitioner, as well as pharmaceutical technologist, we have to consider all properties, which includes physical, chemical, biological properties of a molecule and its effect on human and animal health. So I'm a Royal Society fellow based in Scotland, St Andrews, and this particular talk will touch upon various points, and important points would include natural products. Why natural products? Why they are inspiring as medicines, and how the modern medicine is benefited because of these naturally found chemical molecules. I'll also elaborate more about our state-of-the-art approach to generate derivatives of natural products, and I'll discuss applications of our breakthrough in chemistry in accessing these compounds. And I'll again, I'll apologize if some of you find it very, very chemistry heavy. I'll try and make it as light as possible. The focus of today's talk would be on antibiotics. But before antibiotics, I would like to just mention about natural products. It's nothing new for any pharmacy professional to know about natural products, but be it ancient Indian medicines, Chinese medicines, or Egyptian medicines, all these sciences have evolved and were inspired by nature. Initially, it was all use of plants as medicines. So we had plant-based compounds, be it crude plant leaf decoctions or otherwise parts of all these natural elements of plants used as medicines. Um, just for example, even tea is useful as a stimulant. It contains caffeine. Chemistry proved it. We know the science behind it now. But in the ancient days, it was just used, and no one knew. So it's used for recreational beverage. But there are properties like this. So, for example, the modern drug aspirin, it has got its roots in methyl salicylate, salicylic acid, and discovery of those. So our ancestors were great philosophers and scientists, and they realized the importance of medicinal properties of naturally occurring compounds. So the first initial focus was on plant-based medicines. Later on, as the science started evolving, the focus started shifting towards other sources of natural products, in particular microorganisms. And microorganisms provided wealth of new types of molecules with great medicinal properties. Discovery of penicillin is very well known. It comes from a mold, and it is one of the first natural product antibiotic to be discovered. Penicillins, it's semi-synthetic as well as synthetic analogs. They have relevance right now as well. Be it ampicillin, a drug discovered during 70s, it is still relevant. We find drugs like vancomycins, erythromycins. The importance of all these antibiotics have increased right now. The world is facing through this COVID pandemic, and a lot of these antibiotics are being reused or repurposed to save millions of lives. If you look at the discovery profile of antibiotics, what you will notice is there is a big void in new types of antibiotics being discovered. Since about 1990s, there are very few new classes of antibiotics being discovered. What I mean by new classes, we'll just have a quick look at the general modes of actions of antibiotics. This is again the textbook medicinal chemistry. So different antibiotics, they either work on the cell wall biosynthesis like penicillins, cephalosporins, or vancomycin and bacitracins. Some other types include folate synthase inhibitors, nucleic acid synthesis inhibitors, and there are a few natural products, but quite a lot of synthetic drugs in these classes like quinolones. When we talk about quinolones, it reminds of quinoline, and again, quinoline, chloroquine has been a powerful anti-malarial drug. And hydroxychloroquine has again become very popular because of this COVID-19 pandemic. It has shown really good activity to prevent growth of this virus. It can impact on the spike protein being internalized in the cells. Then there are other mechanisms of antibiotics which act on synthesis of proteins. So within the cells, it can either interact with 50S or 30S subunits. And when we look at these names, you find macrolides, chloramphenicol, tetracyclines, aminoglycosides, all of these are natural products. So nature has really blessed us with wealth of very wide spectrum of antibiotics, and these have saved millions of lives over the past decades. When we look at media news, you always find something like this popping up, that we are all going to die. There is multiple antibiotic resistant strains around everywhere. And of course, media exaggerates these things, but partly this is a reality. A lot of previously curable infectious diseases are becoming resistant to available treatments. Hence, there is continuous need to develop new types of antibiotics. And this is where we come in. We are exploring to discover antibiotics which has got new unique mode of actions. And hopefully with these new antibiotics will overcome the issues of multi-drug resistance. So when we talk about antimicrobial resistances, uh, there is a simple, straightforward guideline, and as a pharmacist, we educate common people all the time about this. With the current COVID-19 pandemic, this is all has become more obvious. So if someone is sick, stay away from crowd and keep your hygiene. Uh, take your antibiotics properly. Complete your courses, and that is all becomes really important. So World Health Organization keeps sharing these guidelines, but as pharmacists, it's our role to educate the people. Right now, with the COVID-19 pandemic situation, everyone has become more familiar with these things. So hopefully, uh, we can see light at the end of tunnel, and we'll get rid of the COVID very soon as well. Uh, but it is up to us, be it clinicians, be it pharmacy practitioners, or the common patients. Everyone has got a role in tackling these antimicrobial resistances, because if a patient is not complying with the given therapy of antibiotics, there is always a chance that the small amount of remaining microorganisms within the body can develop resistance, and then in future it becomes a problem for next generations. Okay, so coming back to the main theme, natural products. If you look at the drug discovery profile and summary of drugs discovered since 1980s, almost 70% of new antibiotics are either natural products or they are derivatives of natural products. So you can see like this is a huge 3/4 of all drugs, they come from natural products. And that is one of our inspirations as well. When we look at these chemical structures, these are all unique molecules. Some of them contain sugars, some of them contains large cycles, some of them contains small aromatic rings, and all these have been life-saving drugs. So natural products are medicinally relevant for discovery of new natural products, as well as to develop them as potential drugs. We need analogs. We need to get derivatives of this to understand their structure activity relationships. Derivatives are also important to tune and control their pharmacokinetics and pharmacodynamic properties. We have to control their absorption, metabolism, elimination, thereby reduce the side effects and optimize the desired effects. So natural product discovery is one aspect, whereas making derivatives of it is equally important in medicinal chemistry. But when we look at such complex structures, they are not always easy to make. In our labs, as I mentioned, we focus on antibiotics with new, unique modes of actions. In recent years, a new class of antibiotic natural products had been discovered. They are called uridyl-based natural product antibiotics. All these structures here, you will find that there is a uridine fragment which is a common motif attached with very complex architecture. The compounds like tunicamycins, capuramycins, they are structurally very complex, but these have been isolated from various microorganisms, and they have potent antibiotic activities. In some cases, they are very, very selective against either gram-positive, gram-negative, or selectively against pathogenic as well as multi-drug resistant strains of antibiotics. There is another class of uridyl peptide antibiotics, and they are summarized here in these structures. These all contain a modified uridine core along with a peptide type backbone. And all of these are isolated from streptomyces, and our lab has been taking a leading role in discovery of these natural products as well as unraveling their biosynthetic pathways. And our lab has developed expertise in making derivatives of these antibiotics. How do these uridyl peptide antibiotics work? As I mentioned, they've got a unique mode of action. They act on cell membrane, but in specific, they act on peptidoglycan biosynthesis. The target for these antibiotics is a protein called MRAY. It is a cellular protein, and that is required for conversion of lipid 1 to lipid 2, and that is a critical point in cell wall biosynthesis. If this can be inhibited, then new bacterium cannot generate cell wall, and hence they die. So very simple mechanism, but quite distinct to penicillins and other classical antibiotics. If you look at the MRAY, these are the proposed structures as well as the X-ray structures, and it is a transmembrane protein. On the external side of it, it binds with its target molecule, which is an ATP mimic, to say in a simple word. These uridyl peptide antibiotics, they bind to this magnesium binding pocket, and there is a competition. It displaces its natural substrates, binds with the magnesium reversibly but quite tightly, and it inhibits the natural function of MRAY. Once this function is inhibited, cell wall biosynthesis is disturbed. Thereby, the bacteria, be it pathogenic or resistant to classical antibiotics, they all are found to be susceptible. So in these uridyl peptide antibiotics, there is this backbone which contains amino acids and peptide bonds. And at the bottom in the structure here, with a small 5-member ring and ribose, modified ribose, and uracil moiety is the uridine part. So different classes of this family of antibiotics, they differ only in the nature of amino acids which constitute that backbone. Small changes here can cause dramatic change in the activities of these antibiotics. Just to give an example, synthetic analogs of sansammycin have been found to be potent compounds against tuberculosis. Nanomolar activity against drug-resistant tuberculosis has been identified with sansammycin antibiotics. That is not from our labs, but yes, these antibiotics can be tuned to target selectively one or multiple types of bacterial infections. When we talk about structure-activity relationships as a medicinal chemist, that is something which I am always keen to know. Okay, this is the structure. What do we know so far? Did people study about it? And in this structure, what is shown as highlighted, the uracil part, the enamide part in the green box, and the central core, which I have labeled as DABA, DABA, 2S, 3S, DABA, these units are very, very important and essential for activity. Now, this DABA is an unusual small diamino acid. Any changes to this amino acid can abolish the activity. However, so far, scientists could not find out how this is biosynthesized and why it is so significantly important. So in our labs, we got a program to synthesize analogs modifying at this center of the antibiotic and to study their effect. Otherwise, in the backbone amino acids, towards the N-terminal, polar amino acids, they decrease the activity, so we want non-polar amino acids. Towards the C-terminus, aromatic, electron-rich amino acids are essential for activity, whereas in between, the R2 position is quite flexible and there is a wide variety of amino acids that can go there. But if you want to study the full structure activity relationship, we have to make these compounds in lab. How do we make natural products? One of the most common method, the traditional method, is total synthesis. So we start with a small building block, do your successive chemistries, and build up the target molecule. However, natural products are complex, and total synthesis can be very lengthy and challenging. So on this slide, I'm just highlighting if we want to assemble one molecule of uridyl peptide antibiotic, what we need is 9 steps to access the central core, which is DABA, 7 steps to prepare the uridine analog in blue here, 2 other steps to install the urea bond shown in pink, and you need additional 5 to 6 synthetic steps to stitch them all together. So we are talking about 20 to 25 step synthesis, and there are so many chiral centers. So along the way, we have to look at the chiral centers. Is it all intact? Has the chirality been impacted? It can have very big implication in the final activities. So total synthesis, yes, it is one of the best ways of doing it. That is the traditional way. That's how people have done it all the time. But it is very tedious, can be time consuming, can be very expensive. So what are the alternatives? Can we make it any easier? So the other common way used in natural product discovery is precursor directed biosynthesis or mutasynthesis. And this is particularly useful for natural products discovered from antibiotic, from the microbial sources. You can feed derivatives of the precursors and let the microorganism absorb it and incorporate into the final natural product, and you just isolate the derivatives of natural product. The only drawback to this is you have to rely on one derivative at a time. So whatever substrate you feed in, you get the corresponding derivative of the product. So to overcome all these drawbacks, our lab has initiated and started this new program, which is called genochemetics. What we do is we insert a new gene along with the biosynthetic gene cluster into a new organism. Thereby, we generate natural product which contains a small handle. This handle can be orthogonally transformed into a new class of compounds. We commonly use the cross-coupling chemistry to transform these handles. So how does it look? You start with the natural biosynthetic gene cluster, add a new gene in it, transform into a new bacteria. Bacteria will do the hard work and produce the natural product with a handle on it. And we do one-step chemical reaction and get new analogs of it. So in our genochemetic approach, the first application was again on pachydermycin synthesis. So on the natural biosynthesis, tryptophan moiety is used and incorporated into the final bacillamycin product. What we did was identified an enzyme, PRNA, and used the gene for this enzyme and transformed along with the biosynthetic cluster of bacillamycin. What it does is PRNA makes chlorotryptophan from tryptophan. And then this chlorotryptophan is used by the biosynthetic machinery to produce chlorinated antibiotic. So now we use this chlorine shown in red here as our handle to make analogs. We do cross coupling, and you can change the cross coupling partner and get new derivatives which are very selectively changed in the molecule. So that really makes the approach very attractive. Now, this approach has been applied on the plant natural products, and independent labs have used our technique, our chemistry, to modify these complex looking alkaloids. And you can produce analogs of these natural products, send it to the lab, get it tested, understand the SAR, and then design better strategies to develop them as drugs. So I realize I must be running out of time. So I'll just rush through a couple of slides here. But one of our focus is on developing mild cross-coupling chemistries. And these have got huge importance in medicinal chemistry as well as within pharmaceuticals. There are a variety of cross-coupling chemistries. Our focus is predominantly on Suzuki-Miura cross-coupling reaction because it can be done under very mild conditions, even at room temperature. It can be done in water in the presence of air, and that's very, very easy chemistry. Over the years, over the past decade, our group has developed a lot of selective, simple methods to achieve these cross-couplings. But this particular slide, it shows quite a few popular blockbuster drug molecules, and there have been very, very life-saving drugs here. Like, for example, imatinib is an anti-cancer drug, blood cancer drug, and the bonds shown in blue here on all these molecules are created by cross-coupling chemistry. So we can see, like, very important, even antiviral drugs and anti-diabetic drugs. Cross-coupling chemistry is one of the top five reactions used in medicinal chemistry. So it's really important. Our group has developed a lot of mild water-based cross-coupling reactions, and we have shown applications for modification of natural products. So reactions like ketorylation, Sonogashira, Heck, Suzuki-Miura, the Buchwald-Hartwig amination, all of these, they generate new type of analogs starting with halogen-containing starting material. So our toolbox of generating variety of analogs is really rich. And what we have done was we developed Suzuki-Miura in such a way that the reactions can be done in bacterial cultures. I'll just skip this. There is a general mechanism of Suzuki-Miura cross-coupling reaction. If anyone is interested, we can discuss things later on. But for our genochemical approach, our idea was, can we generate new antibiotic in the flask, do the chemistry in the same flask, and get the new derivative directly from that one culture? To do so, we have to develop some very mild cross-coupling chemistries. We started with unprotected amino acids, developed those synthetic methodologies, applied it onto some simple peptides, and once the method was available which worked in water at mild temperature in air, we used it onto the cultures. So in this case, what we have done is we took a flask which contained the engineered microorganisms, you grow them, the bacteria produces the halogenated amino acid, in this case, tryptophan number 2. We add the chemicals, cross-coupling reagents, to the same culture media. leave it incubated, and what we get is 2A as the product. So you don't see anything, all the hard work is done by the bacteria, and as a chemist, my job is very easy. I just go take out the desired product. And the advantage of this method is bacteria is continuously generating number 2, and our chemical methods continuously generates the desired analog. We then use this approach onto the complex system, our favorite bacillomycin. So again, the bacteria is doing hard work producing the complex molecule 3. As a chemist, throw in all the chemicals and isolate the analog of it, 3A, in very, very easy method. So that simplifies the job as chemist. But again, we have got a toolbox of chemistries so that we can prepare and get different types of analogs. All these compounds can be tested, and we can understand the SAR and develop better drugs. In the course of doing all this, we came across one particular thing. To make the halogenated molecules, chemical industry uses very old processes. These are toxic, costly reagents, and they're not selective. Whereas in our group, we have developed several enzymes that can do halogenation reaction in a very simple way. It works in water, uses salts, and at ambient temperature. So we came up with this concept. Can we take sea salt with our enzymes and prepare halogen containing molecules? And indeed, our process works so well that now we are spinning out a company called XGenX. I'm leading the company in developing these enzymes for late stage halogenations. So anyone interested in knowing anything more in detail, please feel free to contact us. We'll be very happy to discuss. Okay, there is some issue. I'm hearing myself again, probably from recording, but this is where I would like to stop. I work with Professor Gauss. I'm really thankful to her for her mentorship and for providing the opportunity. And I should end my presentation here. Thank you very much for listening. I'll be very happy to take if you have any questions. And it was a little rushed in the end. Honestly, I felt a little strange because I was talking to my slides without really knowing what's the reaction from audiences. I hope it wasn't too heavy. Thank you very
much, Dr. Sunil Sharma. It was a wonderful, wonderful talk, a game changer. That the buzzword is new. A new natural products, new gene insertion, and new technique of genomatics. You're making new drugs against infection, antibiotics, new drug against something amazing. That is the drug-resistant tuberculosis, vancomycin, and new drug against cancer, imatinib, and new drug against hypertension, diabetes. Valsartan is now picking up like anything. So you're giving new hope and new achievement. What more can we expect? And obviously, it's a Nobel Prize winning research quietly being done. Thank you very much, sir. So with this, we can open up the platform to any questions. Okay, so can I ask you one question myself?
Yes, please.
Now, can we do this research with the end in mind? For example, I want to find out something against Pseudomonas. Now, can we start like with that and go ahead and do this? Is it possible, or it is too complicated to go that way?
No, there are both ways, and everything is valid. So in our labs, our focus is on developing tools to help medicinal chemistry so that the drug discovery can be accelerated. And our approach is being adopted by industry to solve their problems. So that is one approach where we start with molecule in mind and develop it further. what you're asking is the end use specific, and that is more important, because then you know what is the current clinical problem, what does patient need, and how do we solve that problem. That approach, yes, that is being considered, and I'm very proud to say academic labs are the main initiator in this type of research. So the place where I live, Dundee, they have got a big focus on target discovery, new target discovery for microbial diseases, for infectious diseases. And what they do is they study the organism, the target final organism, understand all the biochemistry of that organism, then compare it against the human genome, human enzymes, and try and identify what in that microbe can be selectively targeted. Once those targets are identified, it is combination of computational chemistry, medicinal chemistry, pharmacology, microbiology, all these molecular biology, everything comes together to start discovering new molecules. So yes, new approaches are continuously being studied. There are lots of ignored diseases and lots of other things. So the simple answer is yes. Is it happening? Yes, it is happening. And academic research labs are leading that side of things in the area of antibiotics.
Thank you, sir. Thank you very much. It was a wonderful talk, wonderful discussion. Thank you. Now we are moving on to the second speaker, Dr. Sally Arif. She is an assistant professor, pharmacy practice at Midwestern Chicago College of Pharmacy, USA. With your permission, Dr. Sally, I'll say that you are loaded with pleiotropic pharmacist skills. You are an all-round performer of every skill of pharmacy. I'm really impressed. Your special skills, a collection of precise knowledge and dissemination of accurate information. PowerPoints are really unique. I've seen those PowerPoints, one of the best I ever saw. PowerPoint number 6 is a real excellent PowerPoint. I'm waiting for that. Her presence is assured and felt at all important conferences, CMEs, and journals. She is today going to tell us about the use of ARNI, that is valsartan sacubitril, and SGLT2 inhibitors in reducing the mortality in the reduced ejection fraction type of heart failure, a very interesting and relevant concept. Dr. Sally has pursued knowledge, and the awards and recognition have pursued her. Among many other achievements, she is a board certified in cardiology and pharmacotherapy specialist. With this formal introduction, I present to you Dr. Sally A. Arif, and the stage is yours, Dr. Sally. Thank you.
Thank you so much for that wonderful introduction, and I am so honored to be part of the conference with RAC College of Pharmaceutical Sciences. I have a special place in my heart as I've collaborated with the college for the past 6 years or so. So it's very nice to see some familiar faces. Hopefully everyone can see my screen just fine and hear me okay. It's pretty early here in Chicago, Illinois. So you all are winding down your days in Dubai, and here we are just starting our day here. But I'm excited again to be here today to talk about one of my areas of practice, which is cardiology, and specifically talking about how do we optimize heart failure treatment in this new era as we focus on some new updated guidelines from the American College of Cardiology and the American Heart Association, as well as globally thinking about heart failure as a burden for many patients, with over 26 million individuals around the world having this diagnosis. And as our population continues to age, we see this increasing in number. So I'm excited to be here. I'm, like I mentioned, a clinical pharmacist in cardiology. I practiced for the last 11 years at Rush University Medical Center in downtown Chicago. We are a over 700 bed tertiary center. We've been key to helping with the COVID pandemic this past year in our city and in our area of the country, but also one of the leaders in cardiology management in the Midwest. So excited again to be here. My hope is in our short time that you'll be able to walk away with understanding how we optimize medical regimens for patients with heart failure, specifically looking again at these updates in the guidelines, as well as what are some benefits and barriers to some of the new sequences we're using when we titrate guideline-directed medical therapy in our patients with heart failure with reduced ejection fraction. And I'm going to be referring to heart failure with reduced ejection fraction as HFrEF for the continuation of this presentation. And then I also wanted to bring in one of our new drug therapies, so using the SGLT2 inhibitors, which traditionally have been used in diabetes management, but seeing what the evidence shows us with treatment in patients with HFrEF. And then lastly, discussing the expanded use of Entresto, which is sacubitril valsartan in chronic heart failure, as that's been a new labeling change for that medication. Now, just to give us some background or leverage for where we're starting from, we know that with heart failure, mortality, hospitalizations continue to increase. We know the 5-year mortality rate is as high as 75% for patients with this disease state. We know that previous guidelines have recommended the use of ACE inhibitors and angiotensin receptor blockers, or ARBs, as well as more recently with Entresto added to the market with angiotensin receptor neprilysin inhibitors, but adding these to background therapy with beta blockers and aldosterone antagonists. But often we know that many patients with HFrEF are not prescribed guideline-directed medical therapy, and we know that literature continues to be produced and published where we see that the guidelines needed to be updated from 2017 with regards to some of these new drug classes, and where do we fit these into treatment? So that's really the question. And we know with heart failure, this is a progressive disease state. We see those hemodynamic changes, the activation in neurohormonal systems, so the RAS system, the sympathetic nervous system, which all contributes to cardiac remodeling over time. And that eventually leads to this left ventricular ejection fraction reduction. So really, affecting the pump of the heart, which leads to increases in left ventricular volume pressures, and eventually, unfortunately, leads to cardiovascular events, which can include sudden cardiac death for patients with really advanced heart failure. So we know, again, this is a disease state that happens as patients age, but also we're seeing younger and younger patients with these hemodynamic changes occurring. We know that treatment goals, however, even with the updated guidelines in 2021, still include an emphasis on looking at improving symptoms, improving the quality of life for patients so they can continue to work, continue to be part of society, continue to be active in their lives with their families. And we want to see them not in the hospital setting. So I often jokingly say to my patients that come in as an inpatient clinical pharmacist, I don't want to see you in the hospital. I want to see you in the clinic, and hopefully not often, right? Because the goal is, again, we're reducing hospitalizations, we're prolonging life, we're initiating guideline-directed medical therapy as soon as possible with that diagnosis. We're titrating to target doses that we've seen are effective for reduction in mortality and improvement in survival from our guidelines and our clinical trials. And of course, as pharmacists, we're always focusing on improving adherence. Again, we can put patients and prescribe patients all the best therapies, but if they're not taking them, it doesn't matter. So really talking about motivational interviewing, really getting at the root cause of why patients don't take their medications, their diuretics, their beta blockers, and providing that counseling is a really essential part to my job as I think about discharge planning with many of my patients. Now, to really get into the treatment algorithm. So the new 2021 heart failure treatment algorithm, the difference here that I want to point out on this slide is that ARNIs, or angiotensin receptor neprilysin inhibitors, and currently in the global market, there's only one, Entresto, have really been pushed to the forefront to be used right up front with beta blockers when patients are diagnosed. Now, granted, we've often used ACE inhibitors and ARBs alongside with beta blockers, but what the guidelines are really incorporating now is new evidence, specifically from Paradigm trial, which I'll go over with you today, to enhance the use of these medications or this medication early on. Now, this is in addition then later to therapies that we already know are part of guideline-directed medical therapy, including aldosterone antagonists like spironolactone, including diuretics for symptom approval like furosemide, adding ivabradine if needed, if 2 beta blockers, if heart rates are still above 70 and patients remain in sinus rhythm, and then using hydralazine and isosorbide dinitrate if they've already been added with beta blockers and ACE inhibitors or ARBs or ARNIs now. Now I'm going to come back to the SGLT2 inhibitors, as you can see here, because those have also been added. And again, these are traditionally used in diabetes management. However, now we're seeing it being used in heart failure management. So I'll go over some of that evidence with you and why that is. But I want to start with this direct to ARNI approach from the 2021 guidelines. Now, traditionally, we've transitioned patients away from ACEs and ARBs because we're seeing further reduction in mortality and morbidity when we go direct to ARNI. So this is an update to the guidelines, and they're calling this direct to ARNI. They're saying that this is something that we can be using as early as New York Heart Association Class 2. So these are patients with milder symptoms of heart failure. And we can even be using this when patients are actually not stable per se, meaning they have some congestion, they have some issues with being wet, having pulmonary issues, edema. So this is something that we can do before patients necessarily are not stable. Now the combination in the ARNI is sacubitril, which is the unique new medication we're using that inhibits neprilysin, which allows for natriuretic peptides concentrations to go up. And when we have higher natriuretic peptide concentrations, we get better diuresis, better vasodilation, or counteracting some of those neurohormonal activation pathways. We're decreasing aldosterone and fibrosis that leads to remodeling. So all really great things in this unique mechanism. Now, valsartan is the combination in ARNI, and this is a drug that we've had on the market. We've used ARBs in the past early on in therapy, and we know these block angiotensin II receptors, which decrease sodium and water retention, vasoconstriction, and fibrosis. So really focusing on the RAS system. But all of this goes to improving left ventricular function, decreasing the potential for ventricular arrhythmias, which lead to cardiac death, often in patients with heart failure, reversing remodeling, and improving mortality or survival, I should say, as well as hospitalization. What drove us to direct to ARNI approach in the 2021 guidelines is really this pivotal trial called Paradigm HF. This was a double-blind, single-blind run-in period-based randomized controlled trial, which looked at Entresto versus enalapril as the comparator arm, so kind of looking at ACE inhibitors, which were standard practice in heart failure, and looking at the hard clinical outcome of cardiovascular mortality or heart failure hospitalizations. You can see with baseline characteristics in Paradigm that these patients did have left ventricular ejection fractions less than 40%, so defined as heart failure with reduced ejection fraction. Many of them actually had mild heart failure symptoms with New York Heart Association Class 2, but also seeing Class 3 and 4 symptoms as well. Many of these patients were on background therapy with diuretics, beta blockers, our mineralocorticoid receptor antagonists, so good background therapy as well. And the results were really significant. We saw a dramatic, not just statistical, but clinical reduction in cardiovascular mortality and heart failure hospitalizations. You can see the number needed to treat in Paradigm was 21. And in the cardiology world, this is very significant. So treating 21 patients with Entresto reduced cardiovascular mortality and heart failure hospitalizations for every 21 patients. And from a safety standpoint, you know, the only big concern we saw with Entresto was just a bit more symptomatic hypotension, which going back to the mechanism we kind of expected given what inhibition of neprilysin results with vasodilation and diuresis. But we saw actually less hyperkalemia than we did in the ACE inhibitor arm. So this is really what drove kind of adding to the evidence when it came to enhancing direct to ARNI approach. The other two trials I want to briefly mention were Prove It HF and Evaluate HF. Now, these didn't look at hard outcomes like cardiovascular mortality. However, you see when they looked at the intervention of Entresto in Prove It HF, which was a prospective single group study, and with the RCT Evaluate HF, comparing again to enalapril, we looked at some other kind of surrogate markers. So natriuretic pro-BNP levels, we looked at left ventricular end diastolic volume indexes, left ventricular end systolic volume indexes. We looked at aortic stiffness in Evaluate HF, and again, saw that there was actually structural as well as functional improvements in patients that were on Entresto, often seen at the 12-month mark in both of these trials. So again, something that is part of chronic therapy, we're not seeing these improvements right away, but again, knowing the high mortality rate by 5 years, it's important to kind of consider some of this evidence. So with this direct to ARNI approach, what are things that as pharmacists we need to consider? One, from a safety standpoint, we know it's mandatory when we're switching patients from an ACE inhibitor that they might have been on previously to Entresto, that there must be a mandatory 36-hour washout period. The rate of potential angioedema is very high, which is a huge safety concern. So we need to, be monitoring for that washout period very closely. We also need to consider the symptomatic hypotension with monitoring fluid status and the use of diuretics in that initial period, watching the blood pressure, checking electrolytes like potassium, checking renal function, considering, titrating some of their other antihypertensive medications or diuretics. In our clinic, we found some patients have had a reduction in their other blood pressure medication doses. We've seen actually decreases in loop diuretic use when patients are started on Entresto. So considering all of these things, also considering the right starting dose. We are very careful with this hypotensive concern with ARNI, so we start typically lower doses. So if they've never been on an ACE inhibitor in ARB, we typically start the 24/26 combination medication twice a day. If they're already on a high dose ACE or ARB, we're starting sometimes at the mid-range, but we're never getting patients directly on the high dose of 97/103, right away. We are titrating to that if we can, if their blood pressure has room or tolerance for that. But however, we have to be careful at the beginning when starting these medications. We also know, outside of hypotension being a concern, that in the US at least, the coverage of this medication as a brand only medication at this time can be a high cost for a lot of our patients, so we have to consider that. Like I said, if patients can't afford medications or don't know why they're taking them, they're not going to take them. So we have to consider, again, the guidelines may say these are great from an evidence standpoint, but are my patients going to be taking it? Can they afford it? So considering that and working with our case managers to evaluate cost to patients, access to patients, but again, stressing the fact that this is going to further decrease cardiac death, hospitalizations, and considering if we can't put them on an ARNI, we want to still titrate ACE inhibitors or ARBs that they can afford to be on to target doses seen in our evidence from our trials that, again, best reduce cardiac death and hospitalization. So I'm going to move on now to talking about an extended or expanded indication that just happened this past February for Entresto in chronic heart failure. And I highlight chronic heart failure because we are starting to see a shift away with how we categorized heart failure. So I'm going to talk about that. But just to give you an idea of where this chronic heart failure comes from. So in 2021, this year, Entresto's labeling has expanded to an indication for reduction in cardiovascular deaths and hospitalizations in patients with a left ventricular ejection fraction that's below normal. So a number was not given. And the reason for this is we know that LVEF is a very variable measure. So it's important as clinicians, we think about judgment and we get away from just looking at a number to drive the way we treat. So thinking about the fact that heart failure is a very complex clinical syndrome. Patients, we often used to say diastolic dysfunction, systolic dysfunction, we got away from that. Now we're saying heart failure with preserved EF and heart failure with reduced EF. But knowing that patients in the real world are going to have a very mixed picture. This is a spectrum. So patients can have some systolic dysfunction with diastolic dysfunction, that, the pathophysiology is quite complex. So we have to think about that. And on a global level, this is really being considered. So there was a consensus statement that was just released this March by a universal or global group of heart failure experts from various countries and societies, coming together to say, you know, it's time for us in cardiology to think about classification of heart failure differently. The proposed definitions, or the 4 classes that were brought up in this consensus statement, is that we should look at heart failure again as a spectrum. So yes, we have patients that have reduced ejection fractions with less than 40%. And this is going to be important to our trials and how we enroll patients in our trials. But we also have patients with mildly reduced EFs, so somewhere in that 41 to 49% range. Then we have patients with preserved EF that's greater than 50. And then we have to consider a category of patients that are having improved EF. So now they've been put on guideline-directed medical therapy, and we're seeing an improvement in their left ventricular ejection fraction. And this is what they're proposing to be defined by an improvement of 10 percentage points, where now their EF is greater than 40%. And currently, this consensus is being endorsed and is continually discussed by societies like the Canadian Heart Failure Society, the Heart Failure Society Association of India, Australia, New Zealand, and the Chinese Heart Failure Association. So, you know, more to come in this realm, but just to kind of give you an idea that heart failure is being looked at differently. Now, kind of switching gears back to that labeling for chronic heart failure, where did this come from? In the United States with the FDA, and now the European Society of Cardiology and the EU is looking at this as well. So in the Paragon heart failure study, this really looked at a new category of patient. They included patients with HFpEF, or heart failure with preserved ejection fraction, defined by echocardiography by an EF greater or equal to 45%, and patients who have some degree of structural heart disease as well. So this was a new category of patients that were not included in the Paradigm trial that we looked at before. This was a multi-centered randomized double-blind study that looked at randomizing patients to 2 arms. So Entresto, with a targeting of getting up to 200 milligrams of that combination dosing twice a day, versus a target of getting the other arm into valsartan up to 160 milligrams twice a day. So this was a study that went for a median follow-up of 35 months, but patients were treated for many years. What we found, interestingly, and why we're still a bit confused about this new labeling of expanding to HFpEF patients, is, as you can see the numbers here with this primary outcome composite of first and recurrent heart failure hospitalizations and cardiovascular death, that numerically, yes, there was a reduction in the rate of this composite endpoint for heart failure patients on Entresto. However, statistically, we didn't quite meet what the definition was for a statistical change. It was mostly driven, as you can see here, by a 15% reduction in the rate of hospitalizations for heart failure. So we as clinicians have asked this question now, and we've had many, town halls to kind of discuss, what do we do with this as we apply this data, apply this new labeling to our patient care? And honestly, there's still not a consensus on what to do, because we're quite interested that there was only one trial that changed the labeling, and the statistics here were not that impressive, I guess we can say. When we further dissected the subgroup analysis from Paragon, we saw specifically, as you can see highlighted, that the most potential benefit was seen in this composite endpoint with patients who had a median left ventricular ejection fraction that was less than 57%. So again, highlighting the fact that the worse the heart failure was from a systolic dysfunction standpoint, the better patients did on Entresto versus the ACE inhibitor arm. This spine graph, which was not originally published in Paradigm, but is important to, again, highlight. If we compare Paradigm, which was, again, the HFrEF study, we saw that patients collectively with EFs less than 40% did very well, with the hazard ratio always being less than 1 versus enalapril. But we look at Paragon, which included, again, patients with EFs greater than 45%. Again, the only significant benefit, as we saw statistically, was mostly in patients with EFs less than 57%. So what's happening is clinicians are often not looking at the data, and now they're saying, well, anyone with an EF even up to 60%, 65% should be put on Entresto right away. And that's not really what this data is supporting. When we look at safety in Paragon, very similar to what we saw in Paradigm. So again, we have to consider hypotension was higher in the Entresto arm, and hyperkalemia, not big of an issue. We didn't see a lot of other side effects like dizziness, cough, or renal issues, but again, blood pressure is something that we should still consider in this population. So what have we done with this as clinicians at my medical center? So one thing we've really had a lot of discussions around is that when we think about implementing data, we have to be practical about this. So we have to think about in the HFpEF population, very different than the HFrEF population, we have a very complex cardiac patient to think about that were very much excluded in the clinical trial design. So we did not see a lot of obese patients with BMIs greater than 40. We did not see a lot of patients in this trial with right-sided heart failure without left-sided structural disease. We did not see a lot of patients that we typically see in our clinic that have severe pulmonary disease. These were patients that were excluded when it came to patients like COPD patients who are on home oxygen or on chronic oral steroids. And we also know that these patients typically have very hemodynamically unstable valvular heart disease as well. And these patients also were excluded from the Paragon study. So we had to really sit down as clinicians and think about both our physicians, our pharmacists, who are the ideal candidates. If tomorrow I was walking in on rounds, who would I actually want to put on Entresto outside of HFrEF? And what we came up with was this list. So I'll say this is a level F recommendation because it's based off of our ideas and taking data from the trials and the guidelines and saying, what do we do with this? So we've decided that we'll expand the usage to left ventricular systolic dysfunction that's 40 to 55% on echocardiograph. We want to look at blood pressure, so monitoring that in the hospital system, looking at patients that can have some tolerance for reduction in blood pressure, so systolics at least greater than 110 that are on ACE inhibitors and ARBs already. We want patients who have eGFRs greater than 30. They're already on mineralocorticoid receptor antagonists like spironolactone. We don't have issues with, I'm sorry? And don't have a history of angioedema as well. I wanted to briefly move on to SGLT2 inhibitors. Like I said, these are a new category that have been added to the guidelines. And these are traditionally drugs that we've used in diabetes management, type 2 diabetes management, but we've seen new literature demonstrating reduction in heart failure hospitalizations and cardiovascular disease in patients who don't have diabetes, who have heart failure only. And uniquely, there's many theoretical reasons mechanistically why these drugs actually are beneficial in heart failure. We could spend a whole hour on this, so I'm just going to briefly highlight what the proposed mechanisms are. We know there's a ketone hypothesis to this, so decreasing free fatty acid oxidation, which stabilizes cardiac membrane potential, reduces arrhythmias in potential. We know there's a diuretic hypothesis where there's an increase in osmotic diuresis and natriuresis, an improvement in cardiac function and decrease in filling pressures because of this, and a sodium hypothesis that really looks at increasing intracellular sodium, which then decreases, again, ventricular arrhythmias, decreases sudden cardiac death, and actually improves myocardial oxidative capacity. The EMPEROR-Reduced trial was the second trial that was done in this space, and this was specifically looking at empagliflozin or Jardiance in use in a randomized controlled study where, again, there was a spectrum of different heart failure patients from class 2 to 4. They all have reduced EFs less than or equal to 40%. And what the primary outcome was found to be significant was a composite reduction in heart failure death and hospitalization or worsening of heart failure symptoms. So this was really impressive to us. Most of these patients had a mean EF of 27%. Many of them had diabetes, 50% of them, but half of them didn't have diabetes. So this was adding it on to patients who didn't have a diagnosis of diabetes and were on good background therapy for heart failure. So at the time, Entresto hadn't been approved when the study was being done, so only 20% of patients were, or recently was approved, I should say. So only 20% of patients were on Entresto, but many were on ACE inhibitor or ARBs or beta blockers, as you can see in our baseline characteristics. And you can see here across the board, statistically as well as clinical significance in reduction in that composite endpoint, CV death, hospitalizations, the number of hospitalizations went down also in the paclitaxel arm versus placebo arm. We also didn't have to worry about changes in GFR. We didn't have to worry so much about blood pressure reductions. And when we compared Emperor Trial to DAPA heart failure trial, which was the dapagliflozin study that put dapagliflozin on the market for heart failure. Again, a lot of similarities you can see here. These patients were treated for about 18 to 16 months. We saw significant reductions in CV death. And these drugs are, when we think about how to use SGLT2 receptor inhibitors, these are agents that are pretty easy to titrate. As you can see dosing here, they come as one dose and there's a target dose. You just get them on 10 milligrams a day and you're done. But with this, we have to consider monitoring. So blood pressure, volume status, renal function. These drugs also, because of their mechanism to decrease renal tubular glucose reabsorption, we have to think about some of the UTIs that could come up, especially in our female patients. Clinically, we haven't seen a big concern with this, but again, monitoring for this, thinking about checking GFR at the initiation or baseline of treatment and following up with that. And then thinking about the fact that renal function is important to all of these medications we're talking about today. So to summarize, not to take too much time today and leave some time for questions, what we found from our new updated guidelines, and hopefully it was a quick synopsis that I could have given you today, is that Entresto has become more first line, that using ARNIs should be considered prior to ACE inhibitors and ARBs if there aren't issues with access or cost in the treatment of heart failure with reduced ejection fraction. We should also, as cardiologists or people that work in cardiology or work with patients who have heart disease, who have heart failure, think about adding SGLT receptor antagonists to our treatment regimens for heart failure with reduced ejection fraction, regardless of having a background diagnosis of diabetes, again, to drive a reduction in mortality and hospitalizations. We know that we should always, as pharmacists, think about adherence with these medications, think about helping our teams with regards to monitoring, counseling, adverse effects that should be considered, and that we should always be considering the sequence of treatment. And that's an area that is still kind of being debated and considered as a clinical question, is when should we initiate which drugs? So the guidelines have given us some direction on ARNIs being initiated up front, but then when do we start adding some of our other therapies? And what's the sequence? What should that look like? And how should that be tailored to each patient? So I think we're still always evolving and learning in this space, but I think that goes back to kind of the FDA labeling that just came out for Entresto, is think about clinical judgment. That's just as important as the numbers that we're seeing for our patients with heart failure. So again, I thank you so much for allowing me to be part of this conference today, for all of the organizers, all of your attention. I'm happy to take any questions, and hopefully this was a beneficial presentation to you.
Thank you very much, Dr. Sally. It was a wonderful talk. And the buzzword was change. It was not a message of change, it was a war cry for change. You said time has come, you should consider better drugs. And what is the goal? Reduce mortality. Wherein you are almost playing God. Reducing mortality, you are getting so much more life. You are adding not only life to years, you are adding years to life. Something amazing. You know, not since probably 1776 when the old lady at Shropshire got a digitalis. And that was a game changer. And then came probably the ACE inhibitors. And now the door has opened with two more new entrants, ARNI and SGLT2 inhibitors. It's up to the clinician, so we have to change the mindset. We have to change the order when we use the ARNI. Beginning, not at the end, not when everything fails. Beginning when things still work. And the change should be to start ARNI early and add SGLT2 inhibitors without any inhibitions. And that requires a change of attitude. The guidelines have changed and physicians have to fit in and probably accept the change. And that is what is the message that you are given. I think it was a great message, a great show, and a lovely PowerPoints. I again commend you, very beautiful PowerPoints to give the message and a lasting impression about what you said. Now the platform is open for discussion. I'll have two questions for you, Dr. Sally. One, I saw that your talk was revolving around two of the SGLT2 inhibitors. You did not mention canagliflozin. Many people are still on canagliflozin, as it's a good molecule also.
Yeah.
Why, may I ask you?
Yeah, so I think I didn't mention it just for the sake of time, but there is ongoing work in the space of looking at all the SGLT2 inhibitors, and I suspect clinically that it's going to be a class effect in regards to using all of these agents. I think it's just about which trials actually make it to publication and are considered for drug review. But I think that, dapagliflozin in the United States is the one that currently has the FDA indication for use in heart failure, despite having diabetes, for reduction in cardiovascular disease and death. I think, though, that all of the SGLT2s are going to be approved for that. That's my clinical impression at this point. That's a very good point to bring up.
Thank you. There's one more point I would like to clarify from you with your experience. That is, a country like UAE, we have got intense summer. The summer is really dehydrating. And sometimes we find fluctuations in the creatinine and potassium. But there is no proteinuria. Now, the proteinuria is not there, so it's unlikely to be diabetic nephropathy. So is there a chance for reducing the dose to half? What I'm asking is if it is a class effect or is it a dose effect? Because sometimes we are scared to continue that dose. Though it worked in winter, it worked when hydration was good. And when the intense summer comes, however much they try to keep up with the water intake, slowly the fluctuations start in creatinine and potassium, mainly creatinine. And the clinician gets worried. Is it nephropathy? Should I reduce the dose?
Yes, that's a great clinical point to bring up. We do, as we've started adding on Entresto into heart failure therapy, as well as the SGLT2s, both of them, if you noted in the presentation, do have, from a mechanistic standpoint, potential for natriuresis and diuresis. So we are very careful and of monitoring our patients early on. And you're right, it fluctuates. Some patients are consuming more fluids in the summer than maybe winter months, but really doing a lot of counseling around that. And as clinicians, being very careful about dosing of their diuretics in the heart failure realm, because we know and we've seen a need in reduction in their Lasix and their Bumex or whatever loop diuretic they might be on, regardless of it being HFpEF or HFrEF as a diagnosis. So that has been something beneficial because patients sometimes get excited that they don't have to take as much of their diuretic, but always a balancing act. So how much fluid intake, how much sodium intake is happening, counseling around those restrictions, but then also our duty is to make sure that we are titrating the medications for blood pressure as well as volume very carefully and educating the patient about measuring their weight every morning, making sure they're taking a conscious look at how much fluid that they're consuming. Many of my patients get confused and think it's just fluid like water, but then I think about fruits. So watermelon, for example, is mostly fluid. or soup or other, things in your diet that add fluid or volume on that patients don't consider as part of their fluid restriction. So it's always this balancing act. I think that's where the communication with patients is so key, and for us to be very proactive in how we look at renal function, measure it how frequently. So initially we're doing it at a week mark, and then kind of going to every 3 weeks until we really see how the patient is reacting to some of the new medications, and then also considering, adjusting the other medications if needed.
So thank you very much. It was a wonderful session. And if there are no more questions, I wish to thank you, Dr. Sally. I also wish to place on record my sincere thanks to the organizers. As I always say, it's a pleasure to get involved with this group, one of the most meticulous group in our region, known to have wonderful conferences. So I thank Dr. Padma for giving me an opportunity for this. Thank you.